listeners, welcome to Views on Health. And as yet another Monday evening comes by, we have on the program Dr. Pravin Wijesinghe, consultant plastic surgeon at the Kotalabala Defence University Hospital. I'm sure listeners will recall that we had Dr. Pravin Wijesinghe speak to us last on rhinoplasty. Tonight, the focus is on facial palsy and facial reanimation. Very technical. Over to you, doctor.
Thank you so much, Fatima. It's a pleasure to be back. We're going to talk about a bit of a complex topic, a topic that not many, even as clinicians, not many of us know about. And it's important for me as a plastic surgeon to get the message out there simply because of that, to know that there are options for these patients sometimes. Okay, so the term facial palsy basically means facial paralysis. And the facial paralysis can be due to many things. And facial reanimation basically means we are trying to bring about normal function when it has got paralyzed in the past. Tiny bit about the anatomy. All what we do, all what we express from in our face is due to 17 muscles on each side. So there's 17 on your right side, 17 on your left side, and one muscle right in the middle being shared, which is the muscle around your mouth. All the 17 muscles are supplied by a thing called a facial nerve, which extends or comes from the brain stem, goes behind the ear, comes out just in front of the ear, goes through your parotid gland and supplies all these muscles. And every time we smile, laugh, express sadness, express whatever we need to, all these muscles move to bring about facial expression. Not only does it do that, it also moves the lips, so it becomes an orifice so that we breathe, purse our lips and all that. It also moves the eyelid. So those 17 muscles are critical for expression and function. And the paralysis of those muscles can be caused due to many things. One of the commonest, if you start from the top, right at the top, any brain condition in the brain stem or even further up can cause a facial palsy. Coming further down, if you have a brain tumor in the path which is compressing the nerve, or following surgery which is now also damaged the nerve, because when you have a tumor you have to sort of deal with that first, then that causes a facial palsy. If you have a chronic ear condition which is really severe enough to damage the nerve which goes nearby, that can cause a facial palsy. Any parotid tumor, remember as I said, it goes through the parotid gland. Any parotid tumor that is there can cause a facial nerve palsy. And of course, you have your trauma. What we don't understand is also there's a condition called Bell's palsy, which causes paralysis of the facial nerve, sometimes on both sides, without an obvious cause sometimes. Good thing about it, vast majority of them improve, at least partially, but there are a significant number of people that don't. Unfortunately, as in the infancy, there's a condition called a Mobius syndrome, which causes bilateral facial palsy from birth. So these are the causes of facial palsy. Whatever the cause may be, when it happens, it's got devastating functional problems. If your eyes don't close, eyes dry out, and you can go blind. There are aesthetic problems, especially when there's a unilateral, one side of the face is paralyzed, because when one side is paralyzed, the other side moves and the palsy becomes obvious. If you look at a patient with a facial palsy, if it's unilateral, they almost always show. And of course, with these two problems, there are lots of psychological problems that present with it. So to identify them early and to start treating them is essential. And unfortunately, there's a lot of patients out there because the causes are many. So it's important, if you see someone with it, to get referred to centers that do this kind of surgery and to start their treatment early.
So, doctor, is this a sudden onset? When you said there are these 17 muscles on the left and the right, will both sides be affected at the same time? It will be just one side?
So that all depends on the cause. So remember I said Bell's palsy can be bilateral. And that's equally bad, because you can't close your eyes, you can't open your mouth, you can't express anything, and suddenly it's bilateral. But things like trauma, for example, or a brain tumor on one side will always cause a unilateral palsy and not bilateral. a parotid tumor that gets operated or gets invades the nerve will cause a unilateral palsy. Bilateral palsies are difficult to treat. Unilateral palsies are relatively simpler to treat, but all depends on whether the patients get referred on time.
But it can happen only on like one side. When it happens, it shows drastically, I would think, because we've seen it. And then it also sort of goes towards the other side.
Yeah, so that's very interesting actually. So when you have a palsy on one side, that side doesn't move. So the side that doesn't move or doesn't show abnormally is the side that is paralyzed. The side that moves and you think, oh, it's deviating. No, it's not. It's moving normally. But because the other side doesn't move, it shows abnormally. So the side that moves is always normal. Side that doesn't is paralyzed.
So what's the first step a patient should take? Of course, seek medical advice. But how does he or she proceed?
Okay, so that's a bit of a tricky. The answer is a bit complex actually. I would say vast majority of our patients wouldn't know what to do with it, and they would go to the nearest doctor, and it's up to the doctors to sort of start assessing them, finding out what the cause is. If it's a brain tumor, you need to refer. For example, if it's a brain tumor, you need to refer the patient to a neurosurgeon and not to a plastic surgeon. Don't get me wrong here. If it's a ear problem, you need to refer the patient to an ENT surgeon, not to the plastic surgeon, at least initially. If it's a parotid problem, a person that does a parotid surgery. If it's a trauma, then it's different. Then you can refer to a plastic surgeon initially because we can repair the nerves immediately if it's a cut injury. But all those other conditions, they generally go to the closest hospital, and the surgeons or the treating physicians will assess them. For example, Bell's palsy that I said always get treated by a physician initially, and it's up to those consultants to start referring when the conditions don't improve spontaneously, because when they get referred early, we have a lot more options to the patients than when they get referred late.
Thank you, doctor. So this is interesting, and this can happen basically to people in what age category?
It can happen to you at any age. As I said, you
Even
can be born with it.
That's right. But the palsy?
Generally, middle age is when the palsy happens without a known cause. Bell's palsy happens in the middle age. But all the others, like trauma, for example, it could be to anyone. It could be following an accident. It could be following a stab injury. You can get a parotid tumor at any age. You can get a brain tumor at any age. You can get a ear infection at any age. But Bell's palsy is generally middle age, so they are in the 20s to 40s to maybe early 50s latest. What is important is to know and diagnose it early, because some of those conditions improve spontaneously, and that's good, brilliant, but some don't, and those need to get referred to us early so we can treat them to preserve function before things are lost. So a tiny bit about how nerves work. Nerves are like your electricity supply, and the muscles are like the bulbs. When the electricity goes off over time, obviously the bulbs don't work, but over time the bulbs stop working permanently. So muscles are like that. When the nerves stop firing due to whatever cause, over time the muscles waste away. We need to, if we are to preserve the same function with the same muscles, we need to bring about nerves before that happens. Because after, let's say, a year after the injury, you will not have muscles left to bring about function. So then you need to bring about muscles from somewhere else. And let's talk about that, what the options are.
So what are the options?
Okay, so options depend on how quickly the patients present to you. Let's say the patients come to you immediately. So there's a nerve issue, but the muscles are intact, right? This is completely different for patients who are born with it. Let's talk about that. They are completely differently treated. But if it's an acute problem in an adult patient, as soon as they come to you, we know that the muscles are still there. So we try to bring about the nerve function. If it's a cut injury to a nerve, we try to repair that, and we can repair it with microvascular techniques. There you need tiny sutures under a microscope that can be repaired, and over time it becomes normal. If there is a cut injury with a piece missing, we can bring a nerve from your leg to bridge the gap. It's like connecting a wire. When you have a piece missing, you just bring in a piece from somewhere else. If none of those options are there, we can go to the other side of the face, because we still know that the muscles of the side that is affected are still intact and they're waiting or yearning for a nerve supply. So we can go to the other side of the face, or the same side, take a nerve from somewhere else, like a biting nerve. The muscles that make you bite are completely different to the muscles that move your face during expression. So you can take a nerve from the biting muscle and then connect it. Of course, if the patients come in late, now we have a problem, because now the muscles have wasted away completely. So then what? Even if you connect a nerve, nothing is going to work because there's no muscle to function. So that's when we go in and bring muscles from somewhere else. It could be from your back, it could be from your neck, it could be from your thigh. As far as I'm concerned, I almost always bring about it from the thigh. There's a muscle called the gracilis muscle, which is in the medial part of your thigh, which can be harvested and trimmed to fit the face. That muscle is very long. You need to trim it down to size. You can take it with the blood supply and the nerve supply, and you can connect it to your face, connect the blood supplies separately, and then connect the nerve supply. And over time, that starts firing away. Of course, remember, if you have to bring a nerve first, there should be, otherwise that muscle is also going to waste away. So these surgeries could be a single stage or a multi-stage procedure. It could be multi-vector. Remember what I said in the beginning, 17 muscles, and you're trying to bring in one muscle to replicate 17 muscles, which is never going to be right. But it's better than not having motion on that side. There are other things that you have to consider, like when you have a facial palsy, your eyebrow starts dropping down and covers your visual field. So there are certain things that we can do to lift the brow up. You can do a static procedure or a dynamic procedure for it. On the other side, the muscle that gets affected by a facial palsy also closes the eye. So if you can't close your eyes, you're going to dry out. Right? So you need to bring about some change, do some procedure to make sure your eyelid closes, especially during sleep. So what we commonly do is we put in a gold weight onto the upper lid, and the eyelid closes because of the weight. The muscle that opens the eye is not affected by a facial palsy, so they always can open. But these patients also need to come to us early, simply because if you get an ulcer before we do that, that's very difficult to treat, and the eye surgeons need to get then involved and treat them for corneal ulcers, maybe a corneal graft, and so on and so forth. So it's very, very important that these patients get referred to us very early.
You spoke of removing muscles from some part of the body, and you said you would basically go for muscles from the thigh. Now, whichever part that you remove the muscle to fix within the face, the part that has been affected, where the muscle has been removed from, how does that function? Does it get back to normal? If so, how?
As we humans are perfectly built. In other words, everything has a function. So if you remove something, you do lose some function somewhere. If you take a bit of nerve from somewhere, there's going to be a numb patch somewhere. If you take a muscle from something, if you really assess a patient, you'll have some loss of function. When the muscle that I was telling you about, the muscle called the gracilis muscle, which is the common muscle that is taken all over the world for this kind of reanimation, is a muscle that has function, but when taken out of that part of the body, does not cause a lot of trouble. All you're left with is a scar, but you can walk normally, you can run normally, you can do whatever you've been doing. If you really check, there is some loss of function because that muscle did something in the past, which is now lying on the face. But to have a disability of the face has so much functional, psychological and aesthetic problems. So it's better to correct that even while losing a little bit of function in the thigh. But it's not a lot. It's patients do absolutely fine even after we take it. I mean, we can take it bilateral. We can take it from both sides.
I'm sure we take your word for it, doctor, by all means. But what little will they lose? I mean, is it the mobility or is it
maybe a little bit of power?
Power.
So the muscle that I was telling you about, the gracilis muscle adducts the thigh. In other words, it brings the thighs together. But then there are 3 other muscles doing the same thing. So just by taking one doesn't affect, you don't lose a lot of function. In fact, in many patients, it's insignificant and you just don't feel it. Of course, you do get a scar though. It's a big scar.
But that'll heal, obviously.
That'll heal, yeah. And you gain function on the face.
Exactly, and that scar, it can be covered.
Exactly. Where the face, if there's a facial palsy, especially on one side, it's very obvious because we are emotional beings. We express feelings. When we're sad, it shows. When we are angry, it shows. When we're happy, it shows. And with the facial palsy, it shows only on one side, and that looks abnormal.
And doctor, you spoke of even taking something from the neck, but that will show.
Yes. So the scar that we give a patient during this procedure is the same scar that we give during a facelift. I don't know whether you've heard of a facelift. Facelift is an aesthetic procedure where the skin is tightened on the face skeleton to make them look younger. It's an aesthetic procedure, and it's the same scar that you get. So do you get a scar? The answer is yes. I don't think there's anyone out there that does surgery properly that's giving you doing that without a scar. Every single injury, every single surgical procedure will give you a scar. Of course, we can hide the scar better, and that's what we do. We go make the scar in such a way where it just gets hidden. But if you look for it, there's always a scar.
Obviously.
Yes.
Thank you, doctor, because this is a reality. We got to give our listeners out there the actual situation so that they can have what I would call, information that will help them to make decisions if they need these procedures, which is what is important here. They should know exactly who to go to, where to go to, and what to expect. And of course, definitely they'll be told everything when they come to you or your colleagues, but they should know where to go. That is what is important. So at your hospital, at the Kotalawala Defence University Hospital, you provide this service.
Absolutely. All plastic surgeons that are currently functioning in the government sector provide these procedures. These are costly procedures to be done in the private sector, so vast majority of what we do is done in the government service. And they also get, to a certain extent, they get treated in a priority basis. Remember what I said, more time you take following the injury, the muscle will start wasting. From the day the nerve gets affected, muscles start wasting. So we need to do that. Whatever we do, we need to do it before that. Right? So we can't just preach and not do. So we always give them a certain amount of priority. Not just with that, but at any nerve procedure, we always try to do it as early as we can. So we adjust our lists accordingly. These are long surgeries. These are sometimes multi-stage surgeries. You sometimes put a muscle, it starts functioning well, but it's not as nice when the patient is at rest. So we do static slings, static procedures. Of course, the science is changing very dramatically and drastically, which is good. And people are coming with innovative techniques. So we try to go whenever we can overseas to train every year, basically, to gain new skills. So maybe a year down the line, I'll probably come up with something different to treat these patients.
Could there be any complications?
If they are big surgeries, there could be complications. But with regards to complications, there are reasonable complications and there are unreasonable complications. Reasonable complications should be discussed with the patient beforehand. They should be told. They should be told that there's going to be a scar. But of course, the scar is going to be better than the palsy. But then they should always know that there is going to be a scar. The scars can behave differently in different people. they can, if they take a nerve from the leg, there's going to be a tiny patch of numbness in the leg somewhere. That should be told to the patient. If you take a scarf muscle from the thigh, there's going to be a scar there. There can be a seroma, which is the collection of fluid. I mean, those should be discussed. And vast majority of the patients totally understand if we tell them in a way that they do. So that's why, and it's also time taken. Some of these procedures are 8 hours long. And that's why we try to do them more often than not in the government sector.
How do you cope? 8 hours?
Oh, there are surgeons operating for longer, so it's just about doing more and more.
I know, but when you have these long surgeries, yes,
sometimes.
you do take a break.
Yeah, just
it's only, you're only human.
Yeah.
Thank you, doctor. So interesting. So, doctor, but the complications you spoke of, which you, of course, you discussed with the patient, that they can, it not necessary, but can happen. Is that what you would say? Or?
Yeah. So the complications with any procedure, especially this procedure that I was telling you about, is twofold. You can have complications like bleeding. You can have complications like an infection, which are universal from any surgical procedure. You can have complications of the scar, which is again universal. But there are specific complications that you can get. You can damage certain structures that are now going to the neck or the head, and you don't want to do that. That's where training comes in. You can also do this fancy procedure taking 8 hours and no changes in the sense, there's no animation. And that's a complication in my book. So something's not worked. So what you need to know is you need to be able to manage, and I think that's what training does, that's what a speciality is. It's about not just doing a procedure, it's also about knowing how to overcome complications, which is part and parcel of what we do. No one's perfect. All of us have errors, but it's about carrying your patient through those errors and sometimes complications, and at the end being there for the patient and trying to do what's best for the patient at the end.
And those complications can be addressed.
Exactly. And you need to be with a person that can address those too. If a skin flap dies, you need to be able to be with someone who's going to treat that. You can't just let them go. You need to be there for them at that time more than in the past.
Your take-home message?
Take-home message is facial palsies can be treated. Come early, really early. Earlier the better. Because sometimes what we do with regards to facial reanimation is simpler if you come early. And it's far more complicated when you come late. But even at a later stage, vast majority of patients have options. So come early. Know that there's treatment, not just outside this country, but within the country. And come to the right people. Come on time.
Thank you, doctor. Solid advice. And we end this very interesting discussion on facial palsy and facial reanimation. To you, Dr. Pravin Wijesinghe, our grateful thanks. Consultant plastic surgeon at the Kothalavala Defence University Hospital. Thank you once again, doctor.
Thank you so much.
Thank you to Pumi Idrisinga for technical assistance. I'm Fatima Razi Khader saying good night and looking forward to your company next Monday, same time on Views on Health.